Well, thank you very much for the invitation. And I've had the opportunity to speak to this group some time before. So this talk is actually very informal. You've gotten to hear from one of our stars, Dr. Riccardo Naselli, who, if you don't know, is probably one of the premier electromyographers, nerve conduction people on the West Coast, is one of the members of the editorial board of Muscle and Nerve, which is sort of the journal for the professionals in this area. This talk really is informal, and one of the things I wanted to do initially was a lot has changed in 6 years. I've been with this department a really long time, and there was a moment where really we needed to step forward. And in the last 5 or 6 years, I've hired 16 clinicians, 9 PhDs, and the department's changed a lot. We've actually brought several programs on board. And I thought before we'd talk a little bit about neuropathies, I might have the opportunity to just briefly talk to you about what's going on in the neurology department itself. Many of you probably have friends and relatives where maybe it would be good to know what sort of is available now here in Sacramento. And at that stage, I can never tell if I want these glasses on or off at this point. It's, you know, I can't remember until I try to read something and I can't see it. Basically, as was said, we're very fortunate. Neurology, I've hired a bunch of very young, very talented clinicians from all over, and we actually now are considered. Try this one?
Yeah, it's on, I think.
Okay. We're now one of the top 2% of neurology programs in the United States. We're ranked about 24 out of, I think, something like 500. Oh, okay.
It is on.
Is it on? I'll try a little closer here. Basically, at the moment, we have several things going on. We have, for long-standing, a Center of Alzheimer's disease and dementia. It is actually ranked #1 in the nation now in extramural funding. Does a lot of epidemiological research in terms of looking for risk factors for Alzheimer's. Recently has been funded for total programs looking at kind of health and exercise to try to see if it can intervene with individuals with minimum cognitive impairment. We have a cerebral disease and stroke group. We have now 2 stroke neurologists, are recruiting a 3rd. We have a neurocritical care center now, so people coming in are choppered in. We now have the ability to give, of course, in the emergency room, a clot buster called TPA, tissue plasminogen activator, as well as thrombectomies. The latest recommendations now is that up to 16 hours. So if somebody wakes up with a stroke, we have technology that lets us know if the clot has impaired brain perfusion, and we have 3 neurovascular radiologists that are available that if it's appropriate can remove the clot. The most recent data as of about 4 months ago indicates that in many cases that can improve outcomes significantly. We have deep brain stimulation that we use functional neurosurgeons that we partner with in neurology, where we can use stimulators in the brain to treat tremors for patients with Parkinson's and people with essential tremor. We have a level 4 epilepsy center here at the Med Center, which means that we basically now have the ability, we have a group of now, I just hired another one, so we've got basically 5 epileptologists. It runs 24/7. We're having a pediatric epileptologist join us in the spring, and we actually in September, and we just opened up a brand new pediatric EEG monitoring unit as well as an adult monitoring unit. We are the only facility really in Northern California that can offer EEG coverage 24/7. We have both a pediatric and an adult emergency rooms, and our pediatrics goes up right now to the age of 18. We all practice together. So actually, when we do see patients, we're all in a collaborative room, so we basically share pediatric neurology knowledge with adult neurology. We have one of the best headache specialists on the West Coast, Mark Leonards, and we're building basically a headache center. Movement disorders, we have 5 movement disorder neurologists. Multiple sclerosis, we're bringing additional neurologists to that program. Myasthenia gravis with Dave Richman, we probably have the preeminent expert and researcher in myasthenia, probably again, actually in the United States as well as the West Coast. We do have neuroanatomy. One of the senior physicians, even more senior than I am, actually has written a book on neuroanatomy and teaches both the 1st and 2nd years to make sure that our medical students now have an integrated study of neurosciences. In neuromuscular, that will be what we're sort of talking about today. We have 2 neuropsychologists with 3 fellows and increasing activity both in neurology and neurosurgery. As I said, I've hired 3 pediatric neurologists. We now have 4. Basically they cover expertise, everything from acute inpatient ICU to basically one of them is an experienced outpatient pediatric neurologist with more than 15 years experience, I guess 20. And we also have a sleep medicine program. We'll show you where all this is located. It's now in our new Midtown facility, where we have basically sleep studies that are going 24/7, 5 days a week, and polysomnography on the weekends. We'll talk a little bit more about our neurophysiology. That also runs during the day for patients with neuromuscular disorders. And we have a traumatic brain injury program that is increased with neurologists who are trained in traumatic brain and neurocritical care, who are in neurosurgery with joint appointments in neurology. At the Med Center now, we have, again, because we have residents and fellows, we're fortunate. We have physicians and RNs at the hospital 24/7, which I think is a big difference for taking care of individuals with complicated strokes or with difficult seizure disorders. As I mentioned, we have these monitoring units, and we now have a dedicated neurocritical care ICU, which is 10 beds to expand out to 15, which again are taken care of by people who are actually boarded in neurocritical care, so their expertise is in handling patients with neurocritical care. So it's been a busy 5 or 6 years, but I thought I might bring this up because this is kind of all new, and you might have friends or relatives where some of this is relevant. The neuromuscular faculty right now, we're in the process of expanding it. We mentioned Dave Richmond, who is really studying a new autoimmune disorder called MuSK and has just been funded on that. David is actually, again, a senior neurologist who's had more than 40 years experience taking care of people with myasthenia gravis. Riccardo Maselli, who's an absolutely outstanding electromyographer, and we're bringing additional people on board, but when we get a very difficult case, Riccardo is sort of my go-to. I'm sort of hyped as neuromuscular. The truth of it is my expertise was really back at UCSF years ago. I cloned the gene for McArdle's disease and mapped it. It was the first human muscle disease that got mapped. And when I got here, the dean said, "Oh, you're an expert in neuromuscular disorders." And I said, "No, I'm a molecular biologist." He said, "Yes, you are. You're a neuromuscular person. Read books, basically." It was old school in those days. We didn't do fellowships. It was like, here, go get a 3-volume book and read it. So I actually, unfortunately, see less patients now because I'm pulled out a lot for all of this administrative stuff. When you finally get to a point where you know what you're doing, they give you another job. Pardon? Oh, sorry about that. Yeah, so I'm sort of, my access is a little bit more limited, unfortunately. I go to way too many meetings and volunteer to make dinner, so I feel like I've done something during the day. Josh Dionathan was one of our wonderful residents, and he's now on faculty. He's also expert in neuromuscular. We're training him to be another really star clinician like Mark Leonards. And Zhe Zhang is coming in September, and she's a remarkable young woman, originally from China. Her father is actually a neurosurgeon in Beijing. Hunan, excuse me. Zhe Zhang actually has wonderful credentials. She really did her neurology at University of Florida. She did her neurophysiology at UCSF. She's currently an assistant professor at Baylor. So we couldn't do any better. And she's coming to basically take on some of the stuff that I do, and her expertise is really in neuromuscular. She's done a neuromuscular fellowship. She's boarded. She's expert again in EMG and nerve conductions. So that will be helpful. And we recognize that there's a lot of neuropathy. As I'll say in a moment, it actually exceeds the incidence of restless leg syndrome in the community, particularly in the age above 50. So we're actually have another recruitment out for yet another neuromuscular person to really expand it out. And again, because we have a facility where we can do 5 beds at a time running throughout the day at Midtown, and we have some facilities for children in the hospital, we really have the bandwidth. Our big problem now is I've hired more people than we have rooms to see patients. We've been busy. So this is where we are. This is actually the ranking of neurology programs in the United States based on extramural funding, and you can see we're now number 5 in the country, actually. U.S. World News and Report. I have problems with rankings with stuff like this. The only reason I would even cite World News and Report is they've shifted their metrics more towards patient quality and away from sort of reputation. It turns out that the hospital CEO looked at our patient care and it matches with the top three, which is Mayo, UCSF. The only reason we're not higher is basically we have young faculty and we have no reputation whatsoever, which is fine. That'll be their job. But at the moment, we're actually 26 out of about 500. So we really are about, within the United States, we're regarded, and at this point now, I get a lot of correspondence from other neurology chairs about what we do at UC Davis and what they do at Cleveland and what they do at Mayo. You can see we've gotten busier. The chair of neurosurgery is just coming on board. Griff Harsh is from Stanford, and actually Griff and I overlapped in our training back at UCSF. And Griff has an MBA, and he says he always likes charts where they go up to the up and out to the right. So Midtown, basically, which is where we're at, is I don't know if I put a slide in here or not of Midtown. Midtown basically was designed for neurological patients. I was lucky enough to have some input into the design. It's available for wheelchair and walker. It has 17 rooms. On the second floor upstairs, it has neurophys by day and sleep by night. And basically, in its first year, we've not advertised it because we wanted just to get the thing settled. It was already up to seeing 100 to 150 patients a day. So in our first year, we saw over 12,000 patients. So we're a little frightened, actually. It just turns out, seriously, what we've discovered, and I kind of knew this, was that there's just a large need for care for neurological patients here in Northern California. And that we're getting patients from Nevada, and we're getting patients from Oregon, and we even get patients from Southern California, because it's easier to come up I-5 and see us. So we're sort of becoming, I think maybe 30 to 35% of our referrals are actually outside of Sacramento at this point. So this is a long-winded way of sort of saying, yes, we're growing, we still need to grow, we probably need infinite growth. That'll be for the next chair. And we apologize if sometimes there's a wait a little bit for getting to see us. We're trying. So, neuropathies. This is nothing that you don't already know, I'm sure. The prevalence is actually pretty high, and it increases with people over the age of 55 to maybe as much as 8% of the population. This is back in 1997. We know that there's well over probably 4 to 5 million individuals who have neuropathies, many of whom actually don't know they have them. If you think back to your prior generations, many of your grandparents and parents complained of their legs being cold. They blamed it on circulation. They would often really not want to walk. Their feet hurt. And a lot of those were not circulatory. A lot of those were neuropathies. And it plays a role because what I end up seeing is a lot of individuals who have late onset, but the neuropathy is genetic. We'll talk about that. Also, we're a little concerned right now with metabolic syndrome, with the increasing obesity, because we know that with metabolic syndrome and diabetes, there's an increased incidence of neuropathy. I apologize, this may or may not be a little bit too academic, but I found that at least with residents, it was important to kind of just show what's meant by a nerve. A lot of people think it's kind of a wire or a single strand that comes out of your spinal cord and hooks up to a muscle, and it doesn't do that. This is the spinal cord. These are the roots. This is the dorsal root, and this is the ventral root. And this is where all the stuff comes out of the spinal cord from specific regions, and they fuse to form a ganglion, the dorsal ganglion, and we have those basically throughout our spinal cord, okay? And then sometimes you'll hear with Guillain-Barré and other things that the spinal fluid protein in the spinal fluid is elevated. The reason it's elevated is because it leaks right here where there's inflammatory cells, and it causes protein from the outside to get into the spinal fluid, and that's one of the hallmarks of Guillain-Barré. And sometimes when people have a chronic form of Guillain-Barré, like CIDP, this will heal up and the spinal fluid protein will come back down. And it's really the electrophysiology that lets us know that they've really had either Guillain-Barré or a variant of chronic Guillain-Barré, which we call sort of CIDP. Anyway, this thing forms, a nerve, and you'll notice that the nerve is, what we call a nerve is made up of a whole bunch of peripheral nerves. It's like a coaxial cable, and the nerves are of different diameters. And the different diseases can affect the different nerves and types of nerves. And that's important for us to figure out in terms of figuring out the causes of what the neuropathy may be from. The reason I also bring this up is when you go onto the internet and try to look up the word neuropathy, you'll scare yourself because it includes everything. It's pretty much like saying sports utility vehicle and not distinguishing between any of the different brands. And maybe in a way it's a little bit worse. And so what happens, it's also hard because when you go to the chat sites, everybody may have different kinds of neuropathies, or the injuries were caused by different things, and people respond to different sorts of treatments. And it's also been a problem for clinical trials, and we'll explain that in a minute. So this is not a great picture, but I just wanted to show the different kinds of distributions. You'll have heard of trigeminal neuralgia. Has anybody here not heard of trigeminal neuralgia? Okay, trigeminal neuralgia is a damage, it's still a peripheral nerve, but it's the trigeminal nerve that comes out the brainstem, and people will get shocks of pain on their face, or severe pain that's there all the time. And they will come on in with basically, sometimes misdiagnosed as a headache, but it's really, for instance, they may eat, or cold air will set it off, or a number of things will trigger it, and it's just absolutely incapacitating types of pain. We basically have a kind of a way of dealing with this in neurology. We have certain medications that we can treat it with, some of which overlap with peripheral neuropathies. We also have neurosurgical approaches where we can basically decompress the nerve. We work in partnership with our neurosurgeons, and they basically can perform procedures. And we sometimes, if we have to, either do a decompression of the nerve or a stimulator. But the bottom line is this is one type where the actual pain is on the face, and these are just the distributions of the trigeminal nerve. Another thing we see is postherpetic neuralgia. And many of you are probably familiar with postherpetic neuralgia. These follow the distribution of nerve roots. Now, just for all of you, I myself have had my vaccine for herpes shingles. How many here of you have had your vaccine? Good. Let me explain what that vaccine will do. It will not prevent you from getting shingles again. That's not its point. Its real point is to prevent you from having postherpetic neuralgia. So it is not uncommon for people who've had the shingles vaccine to get subsequent outbreaks. I think my wife has had three or four. And the point of them is after the vaccine, it doesn't look the same. It looks different. It can, because of the vaccination, but its goal is really to prevent you from having a type of damage to that nerve that ends up with a postherpetic neuralgia. Yes? That's a great question. The old shingles vaccine really is the one that I'm referring to. The new shingles vaccine has a higher dose, and it's sort of there's a hope that it will be more effective. It's not so clear because, interestingly enough, although they give it to people over, 60? I actually paid for it and decided I wanted it at 50. More than 50% of people get it below the age of 60. And so, in fact, really the majority that I see are actually in younger people. And you're right, I think the problem we get into is as we get older, our immune system is less robust and we mount less of a robust immune response, which is one reason that they've increased the dose. It's a good question. And we'll have to see how this new one, if it does a better job of preventing it. Yeah. Oh, the first vaccine? That's a great question. You probably, honestly, if it were me, I'd do it. I would still get it. But I think that the data could argue that you already have an immune response and you might not need it. The problem we really have is we don't titer the response. And I guess the concern really is mostly that as we get older, see the vaccine won't, or even having shingles won't cure you of herpes. It doesn't go away. We have about 5 to 7 viruses that live in our body. Yeah. Sure, we can do that. So anyway, we can go back on some of this. Anyway, as we're going through some of this, these are just the different distributions of the different neuropathies that we see, okay? Why do we work these things up? The reason we work them up is because actually, this is what I was studying research in back a number of years ago, peripheral nerves will remyelinate. So if you get a compression injury and you haven't cut the nerve, there is remyelination. It's slow, it's often incomplete. We can still tell when somebody feels perfectly normal that they've remyelinated, but you can remyelinate. The axons can regrow. They regrow better in younger people than older people. Sensory axons grow better back than motor neurons do, and they do best for peripheral neuropathy. Okay? The neuromuscular junctions can reestablish, and that was some of the research I was looking at, was where you could make the muscle regenerate. It has special stem cells called satellite cells that actually live with the muscles and grow back. The autonomic nervous system can't right now regenerate, but can be retrained. For those of you who've ever been in a hospital and say been in a bed for several weeks, you may notice that the nurse will get you up, swing your legs over the bed, you get lightheaded and say, I think I gotta lie down again, and then they do it to you again. What they're doing is retraining your autonomic nervous system. They call it dangles. And basically, a number of things we do with the autonomic nervous system is exercises and physiology things to retrain it. Systemic illnesses can be treated, and one of the things that I look for and referred about are people that have systemic disorders that basically sometimes they present as neurological problems, and fundamentally there's sort of a missed systemic disorder that has to be gotten. Maybe the best shot is to kind of hold questions to the end so we'll get through, and we can go back on some of these. This is obviously a large topic, but basically it's worthwhile getting these things figured out to figure out what causes them. A lot of the internists have gotten very adept at ordering the basic studies and know to do that, and to treat it symptomatically, and to identify coexisting medical conditions. So one of the things we do with neurology is we identify what nerve types are damaged. We identify the location and the causes of the weakness. We talk about different kinds of pain, just in the same way that there's lots of different ways to describe snow if you happen to be an Eskimo. It's very difficult in our culture. We don't really have lots of words to describe the pain, but we really try to get a handle on it because it gives us an idea of also where it's located. And the kinds of pain that you get from damage to the dorsal root ganglia or the posterior portion of the spinal cord is different than other kinds of nerve pain. Okay. We use obviously we use combinations of special drugs. We try to stay away from narcotics if at all possible. We use something called drug synergism, which means that if we use one drug by one mechanism and another drug by a separate mechanism, we can get an additive effect while minimizing side effects. It's called drug synergism. It's where 1 + 1 = 4. We basically try, as I said, acutely we may have to use narcotics. We try to be very careful in them. And the reason for that is we've learned over time that narcotics on chronic use are pro-inflammatory. And that for a lot of patients that I have who have been on fairly high doses of regular narcotics, even when they're not escalating them, a number of them really come back and say, you know, I feel a lot better now that we've kind of dialed off the Tylenol number 3, or we've dialed off some of this. It can be necessary occasionally, and there are obviously individuals that use it as for PRN breakthrough pain, but it does have its downsides, and I think there'll be some new breakthroughs coming through that will help in the future. The other point of this is, and this is, again, do not underestimate the importance of physical therapy and occupational therapy. I think when I was a younger physician, I wasn't as sure about it because the science is weaker than it is in other areas, but the improvements that I've seen in individuals, particularly with motor weakness and even with back pain, and that has been impressive. I myself do it. And so it really, there's a lot we don't understand. There's still a lot that's now becoming investigated at the cellular level. But if your physician recommends physical therapy, obviously it needs to be the right type, but don't minimize it. Let's do this. We're getting kind of to where we want to sort of just answer questions. I think the fundamental thing is this. When I ask our residents who are not neurologists, what percentage of neuropathies do they think are diabetes, they'll always say, oh, 70%. And if you go to an internist, they'll always say, well, it's got to be diabetes, right? Or it's diabetes, or you're pre-diabetic, or maybe it's diabetes. and the answer is no. It may be true that possibly 40% of neuropathies tend to be diabetic. Actually, I see very few of them because they're handled by internists. 70% can be diagnosed. Interestingly enough, probably 20 to 30% of them are genetic. So that a lot of them that I see, even where people are developing neuropathies in their 50s and 60s, they'll say, you know, my mom basically had something similar and she had feet that were shaped like mine, kind of high arched, narrow ankles, and gee, she started to complain about her feet as well. And when we do the electrical studies, it looks symmetric on both sides. It's not asymmetric. And we do the additional studies to make sure it's not an autoimmune neuropathy, and it's not. And then we have the choice of doing a genetic screen, and there's about 50 different genes. So at the time that I cloned the gene for McArdle's disease, there was only two forms of genetic neuropathies known, Charcot-Marie-Tooth type 1 and type 2. It's very simple. We now know that there's well over 50 genes, that they really can present anywhere from infancy to late onset. I've seen presentations of people in their 70s, where basically had we done the electrical studies, they would have been asymptomatic, but would have demonstrated the neuropathy probably in their 20s and 30s, but basically became symptomatic for one of two reasons. Either it was just some slow evolution of the disorder, or in some cases there was a secondary feature, and that's sometimes why you see neurologists. They might be developing diabetes on top of it. It turns out that their nightly cocktail is fine for their spouse, but not for them, given that they've got a genetic neuropathy that they didn't know about. Or sometimes the chemotherapy, which worked okay for other people, becomes really a problem for them because they didn't know they had this issue. Just a suggestion, when you go to look for treatments and stuff, a good place to look is the National Institute of Health and use the .nih. And we'll talk a little bit about it. Most of you probably here, because if you're interested in neuropathies, you've seen these drugs. These are drugs that have been recommended. These are drugs that neurologists use, everything from gabapentin to pregabalin, which is Lyrica, et cetera. And we have certain drugs that we use for certain treatments. Basically, and we'll go to this very last point, basically the problem you get into is twofold. One, in order for people to figure out whether a drug works for neuropathies, they had to pick a population that had a uniform cause or etiology, so they picked diabetes. So you'll find a lot of times that a drug was approved because it was good for diabetic neuropathy, and then your insurance company will say, I'm really sorry, you don't have diabetic neuropathy, we can't approve it. And the answer is mostly because they don't want to pay for it, if you really want to get into it, because the damage is the damage and the nerve, and the drugs do work. So it's unfortunate. It was really for experimental design. It wasn't to limit the use of the drug. I think the second thing that makes it difficult is because it's such a diverse etiologies for neuropathy, is that when they do clinical trials, a friend will say to you, you know, I had a focused light that was put on my feet. You know, there's some groups out there that have used different sort of colored laser frequencies, and they shine them on people's feet. And there is a very small population that have gotten better. But when they tried it as a clinical trial, it didn't work. And part of the problem, again, is that with these clinical trials, you have to have large enough numbers of cases. And so what happens is you'll get a lot of anecdotes. And I guess that's one reason I do recommend start with NIH.gov websites. Look at basically things that are neurological association, because there is a lot of stuff out there. Some of it's actually harmful. There's a substance that's out called Norexin that's got B vitamins in it. And a lot of people take B vitamins for neuropathy, not realizing that vitamin B6 at high levels can either cause a neuropathy or make a neuropathy worse. So you don't want to do that. You're better off if you can. If you need B12, you need B12. And the easiest way to get that is you measure the levels and then you take it sublingually, so it's absorbed. But I would stay away, if you can, from some of these more mixtures of herbal medications, just because there's a lot of stuff in them. We don't know all the things that are put in those things, and they are a mixture of different pharmacologic agents. That doesn't mean you can't use turmeric because it's got an anti-inflammatory component, et cetera. But just be careful what you do and how you research it. That's all.